I'm going to introduce to you Dr. Katie Witkiewitz. She is a Regents Professor of Psychology at the University of New Mexico with a joint appointment at the Center on Alcohol, Substance Use, and Addictions. She's a licensed clinical psychologist and conducts research examining patterns and predictors of alcohol and other substance use, harm reduction, and recovery. Her research is also focused on the development, evaluation, and implementation of mindfulness-based interventions in real-world settings. She's conducted numerous empirical studies on the efficacy and effectiveness of mindfulness-based relapse prevention as a treatment for substance use disorders, prediction of relapse following treatment for alcohol and drug use disorders, and mechanisms of successful treatment outcomes following mindfulness-based interventions to prevent alcohol and drug use. To date, Dr. Witkiewitz has authored 5 books and over 230 peer-reviewed publications. Her research has been supported by grants from the National Institute on Mental Health, the National Cancer Institute, National Institute on Drug Abuse, National Institute on Alcohol Abuse and Alcoholism, and the National Center for Complementary and Integrative Health, totaling over $35 million in research funding since just 2004.
So yeah, I'm going to be talking about our latest work on kind of expanding definitions of recovery and thinking about multiple pathways of recovery. This work is funded by the National Institute on Alcohol Abuse and Alcoholism. Happy to share these slides or any of the papers that are cited. Some of the work I'm going to be presenting is published and some isn't. I'm happy to share any of the published work. And then you can follow me on Twitter. And I would love to follow you back. So feel free to connect with me that way as well. So I'm going to talk about a range of work that we've done in the last several years on harm reduction approaches to thinking about alcohol use disorder, thinking about benefits of drinking reductions, how we can understand recovery from a perspective of functioning and maintenance of functioning. And then I'm going to end with kind of a push that I've been making recently to think about the treatment of alcohol use disorder and our definitions of recovery from a public health perspective. And a lot of this work's been informed by a collaboration I've had in the last several years with Dr. Jaylee Tucker, who has a real public health focus to her work. And so that's really been influential in my thinking about alcohol use disorder treatment and treatment outcomes. So, obviously, I don't have to tell you all work in this area, that alcohol is a leading cause of morbidity and mortality. In fact, we hear so much about opioid overdoses, which are tragic, but alcohol is actually a much bigger killer in our country and globally. And there's a lot of preventable diseases that are either exacerbated or directly caused by alcohol use. And so I want to preface everything I'm saying by acknowledging that there's basically pretty much good evidence that any level of drinking beyond very minimal use is associated with increased harm. And so my goal is always harm reduction. How can we reduce harm? And so, but I like to preface all this by noting that alcohol is a major killer in our country and globally. And alcohol use is increasing. And these are data pre-COVID. But what we know from a lot of reports is that in a lot of settings, COVID has actually increased, alcohol use has increased among some populations, it's decreased among some, but we do kind of fear a next wave of increasing alcohol harm because of COVID. And I also like to acknowledge, though, that, alcohol in many places is part of our society, and alcohol use disorder and even problematic alcohol use is actually uncommon among those who drink alcohol. So the majority of people who drink alcohol drink so in non-problematic ways as far as what we would define as an alcohol use disorder, alcohol-related problems. And so if we look at data from the National Survey on Drug Use and Health, we see that most people drink alcohol in the past year. Majority of people drink alcohol in the past month. And only about a third of people engage in binge drinking, which has been defined as 4 or more drinks for women or 5 or more drinks for men. And only about, depending on the survey you look at, we can say that under 15%, about 10 to 12% probably meet criteria for an alcohol use disorder. And if we zoom in on this even further, this 11% becomes quite interesting, because if we look at the number of symptoms endorsed among people who meet criteria for an alcohol use disorder, we see that the majority of individuals are actually in the mild range. So, 67% meet 2 to 3 criteria, 19% meet moderate, and then really a small subset of that 11%, only 14% meet criteria for a severe alcohol use disorder. And I think this is really interesting when we think about a public health perspective. So it's really, going back to the last slide, the majority of people in the US and probably globally are drinking alcohol at not problematic levels, problem defined by alcohol use disorder criteria. And then even if we zoom into the small percentage, 11% or so, who meet criteria for an alcohol use disorder, only a small percent of them are at the severe end of the spectrum of alcohol use disorder. And so really, from a public health perspective, the majority of people are drinking without problems. Those who are drinking with some problems are experiencing kind of the more mild range of the disorder. Okay, yet, despite all of that, our society, our media, conversations, and in many ways our research groups and research emphasis still kind of focuses on this one-size-fits-all view of alcohol use disorder. That recovery is really, this is from Betty Ford Institute, recovery is defined by sobriety, personal health, and citizenship. And SAMHSA still focuses on overcoming or managing one's disease as defined by abstaining from alcohol. And so, I think it's interesting that from a public health perspective, the majority of people are probably not when we look at the big book. If you look at Alcoholics Anonymous and you look at the big book, that the focus of that was kind of people at the severe end of alcohol use disorder. And yet the majority of people are not at that severe end. And yet our treatment models really still focus on the kind of that severe end. Now, I am going to say this a few times, but abstinence is great, right? I think abstinence is rightly celebrated as success for many people, and is commendable. And achieving recovery through abstinence, I think, is in many cases a great outcome. There is kind of a subset of individuals who are kind of not experiencing good functioning in abstinence, and we could talk about those individuals. But generally, I think what I want to do is not say abstinence is bad, like abstinence is the ultimate harm reduction. But can we also expand beyond abstinence to think about alternative pathways besides abstinence? So that's kind of where I'm coming from. And, is our focus on abstinence letting perfect be the enemy of the good? And so I think this really solitary focus on abstinence as defining recovery has really not considered the fact that reductions in drinking are associated with reductions in morbidity and mortality. So if we look at the global burden of disease risk factor studies, which made huge headlines now almost 3 years ago, it was in the summer of 2018 that this Lancet paper came out. And in this paper, all the headlines said, any drinking is associated with mortality. So you can't have your drink a day anymore. Any drinking is associated with mortality. And that is the conclusion when you read this figure from left to right, as we are trained to do in many Western countries, is reading from left to right, obviously. But if we read this figure from right to left, I think the headlines would have been much different. The headlines would have said, if you reduce your drinking, you're going to potentially experience reductions in morbidity and mortality. And I actually think in a culture that normalizes and even celebrates heavy drinking, that latter headline actually might have been more helpful from a public health perspective. So instead of saying you can never drink again, what if we said, hey, reduce your drinking. Everyone needs to reduce their drinking. And I think from a public health perspective, that might have been a much more helpful message. So then the question becomes, well, how much reduction is associated with improvement? And this is something, I've been thinking about for almost 20 years of doing harm reduction research with drinking. So I would present data on harm reduction, and I would have clinicians and physicians say, well, how much should my patients reduce by? And so that was always a hard question, because I would always say, kind of wish you know, have it be collaborative, talk with the patient, work with the patient, you know, and it would be really nice to have levels of drinking that we could be targeting. And so that's kind of where we've been moving recently, is using the World Health Organization risk drinking levels to try to provide targets for people, and kind of looking at risk, how much drinking is associated with how much risk, and then kind of where do you want to be. And so we use this now collaboratively with clients in our clinic, and we'll say, okay, you're currently at a very high risk drinking level, so your drinking is really putting you at risk for morbidity and mortality. What level of risk do you want to be at? And you know, most of our patients don't say low risk. They're willing to take on some risk. They're willing to be at that moderate risk level, or even a high risk level. They're just saying, you know, I don't want to be at this very high risk level. I do want to reduce my risk. And so this provides, you know, the World Health Organization levels are in grams per day. So we round it up to create this chart, which we actually give to clients and talk about how they can reduce their risk by reducing their drinking. So one of the interesting sidebars is that these risk levels were not entirely validated, and there's a fun story about that, but we wanted to validate them so that we could recommend this to our clients. And so what we have found in several studies now, I think we're almost up to 10. Actually, we just had a paper accepted, so we're up to 10 papers now that have tried to validate these drinking risk level in both clinical trial and population databases. And what we have found in all these studies is that drinking risk reductions, first of all, that they're achievable, so individuals can achieve reductions, and that, as I'll show, they're also associated with improvement. So we find that about 84% of individuals in a clinical trial can achieve at least a 1-level reduction, and these gives examples of that. And about 68% achieve a 2-level reduction or more. And this is important because only about 30% of individuals achieve abstinence in treatment. So individuals who want treatment, who go to an abstinence-based treatment, only about 30% of them achieve abstinence. But when we look at these risk levels, they're actually achieving very large reductions in their drinking, even if they're not getting all the way to abstinent. So they're achieving some success with reduction. And what we find is that in, again, up to 10 studies now, that these drinking risk level reductions, even short of total abstinence, are associated with improvements in physical health, including improvements in systolic blood pressure and cardiovascular disease risk, liver disease risk, and then large improvements in mental health and quality of life. So reducing drinking, even short of abstinence, people who are just reducing, not getting all the way to abstinence, are seeing improvements in how they feel and function. So this is you know, important work to us. The biggest question we always get asked is, how stable are these drinking reductions? The assumption is that individuals who reduce their drinking are going to fall off the wagon and go back to heavy drinking. And we actually don't see that. What we see is that of those who achieve a 1-level reduction, about 84% achieve a 1-level reduction by the end of treatment, and about 85% of them are still reduced by at least 1 level 3 years later. So if you reduce during treatment, your odds of remaining at a reduced level of drinking is quite good 3 years later. And then for individuals who achieve at least a 2-level reduction, similar story, that they tend to maintain those reductions up to 3 years following treatment. And here's a link to this paper. This was replicated in 2 separate clinical trial data sets showing that individuals who reduce their drinking are able to maintain those reductions. And what's more important, I think, is that not only are they maintaining those reductions, but maintenance of those reductions are associated with improvements in mental health and quality of life. And so this shows just kind of those who had no reduction, their mental health based on the SF-12, versus those who have the reduction, and even those who have the reduction but are not abstinent. Because it's important to consider that those who we would expect, those who get all the way to abstinence, would have improvements in mental health and quality of life too. So can people who achieve reductions, even if they're not getting all the way to abstinence, still have improvements in mental health and quality of life? And these data suggest that that's the case. One of the questions reviewers always ask us of our manuscripts is, but what about people with severe alcohol use disorder? Certainly they cannot reduce their drinking without being abstinent. And that's not the case based on the data. We find that actually, and this shows alcohol use disorder severity, that those who reduce their drinking still have improvements in quality of life. They're able to maintain their reductions, and those who don't change their drinking do have reductions in quality of life as severity increases, which is not surprising. So all of this work really points to this idea that drinking reductions are achievable and are associated with good functioning, and they're stable. Again, I want to acknowledge that getting all the way to abstinence is associated with really good outcomes as well, and that I'm not saying we should do away with abstinence for those who want to abstain or for those who have difficulty in reducing. But that I think we should expand to consider reductions as also indicative of success. So again, I want to come to this idea that the abstinence focus of the recovery movement could be at some cost for public health. So, that we know that approximately 20% of individuals with alcohol use disorder seek treatment. 36%, as I mentioned, about 30% achieve reductions or achieve continuous abstinence. So that's only 7% of everyone with an alcohol use disorder. If we think about all the people with an alcohol use disorder, only 20% come to treatment, only 7% achieve abstinence of all of those with alcohol use disorder. But about 77% achieve drinking reductions. So if we think about the 80% who do not seek treatment, what we know is that the majority of them do not seek treatment because they don't want to abstain. So you've got this large proportion of people with alcohol use disorder who are not coming to treatment, they don't want to abstain, and they're probably not severe based on the epidemiological data I presented earlier. So what if we expanded our definitions of success to include drinking reductions? We might engage some of these people in treatment and then reach more people with alcohol use disorder, potentially 40% of those with an alcohol use disorder. So then a big question becomes, can individuals maintain a non-abstinent recovery? And so this is some more of our more recent work where we're thinking about recovery broadly. Can we expand the definition of recovery to not just be focused on abstinence? And I'm going to be presenting data from both Project Match, which was a large clinical trial, 1,726 individuals. We have actually 3-year follow-up data in Project Match, and then I'm going to present some 10-year follow-up data from Project Match. It's a small sample at this point. It was only one site that conducted the 10-year follow-up. But it was 65% of those who consented. So even though it's a long-term follow-up, we still have about 65% of those who could have been eligible to participate in this follow-up. The combined study is another large clinical trial that I'll be working with or presenting, and this was also a large trial, 1,383 people initially. There's a 3-year follow-up study from this, as well as a 7 to 9 year follow-up. And this, again, the sample size gets quite small, but in this case, it was 64% of those who consented to this long-term follow-up. So we're looking at smaller sample sizes, but I think this is important when we think about recovery, because many people think about recovery on a longer time span than just 1 or 3 years. So we really wanted to see how long these reductions are maintained, and can this kind of non-abstinent recovery extend that long? So again, these papers are published, and I'm happy to share them with you, but we essentially found that you could identify what we wanted to do was identify recovery profiles, and we wanted to make that definition of recovery multidimensional. So we're including not just drinking consumption, but also psychosocial functioning, life satisfaction, employment, psychiatric symptoms, other drug use, consequences from drinking. So all of these measures are included in our definition of recovery. And so in Project Match, we had several measures as described there. And combined, we also had measures of psychosocial functioning and quality of life and employment, alcohol and other drug use. And what we found, and this was the first paper we published, which was with Project Match, we found 4 profiles of recovery, as we called them, 4 profiles of recovery. Profiles 1 and 2 right here, which is about 32% of the sample, were what we considered low functioning. So in comparison to the other profiles, as well as if we looked at kind of T-scores, when T-scores were available, these individuals were below the mean on kind of functioning indicators, psychosocial functioning indicators. They were more likely to be unemployed, more likely to have a lot of drinking consequences. And they're kind of split by how much they're drinking. So there was, 16% of them were low functioning and kind of frequently heavy drinking. And so none of them were abstinent. These are the individuals who I would classify as kind of classic fall off the wagon sort of individuals. They were drinking heavily all the time and experiencing a lot of consequences. Profile 2 was sort of interesting. Almost a third of them had achieved abstinence, but they were not functioning very well. So they had below average functioning, even though they weren't drinking very much, if they were drinking at all. And then we had our 2 kind of higher functioning profiles. And the biggest profile was kind of what we would consider a traditional success profile. These individuals were high functioning, they were not drinking much, almost half of them were abstinent. And so good to see, right, that up to 3 years following treatment, about half of the sample was in this very high functioning, infrequent drinking profile. And then profile 3 was quite interesting. It was high functioning individuals that, in fact, their functioning did not differ from profile 4 at all, but they were engaging in occasional heavy drinking, about once a week. None of them were abstinent, so all of them were continuing to have some drinking. But again, their functioning was very similar to profile 4. And it's also important to note that those in profiles 2, 3, and 4 all reduced their drinking considerably from baseline. So even though profile 3 is engaging in occasional heavy drinking, it's much less drinking than they were engaging with when they started treatment. So these were the findings in the Project Match data set. We wanted to replicate this and combine, and I promise this is a different set of data and a different sample, but actually the profiles look incredibly similar. So we again, identified a 4-profile solution, similar percentages, 51% in this kind of high functioning, infrequent drinking profile, 61% of them were abstinent. Again, we find this very low functioning, frequent heavy drinking profile, and then a low functioning, infrequent heavy drinking profile, and nearly a third of them, or over a third of them, were abstinent. And once again, we find this kind of high functioning, occasional heavy drinking profile that did not differ from the infrequent drinkers with respect to any of the functional indicators. And once again, those in 2, 3, and 4 had large and significant reductions in their drinking from baseline. So what this shows us is that it might not just be success and failure based on an abstinence-only definition, that there is gradation here, and people follow different pathways that might involve some drinking and still be very high functioning, and that some people follow pathways where they're not drinking, but they're not actually doing very well and might need additional supports. So we've followed this up to see also how they were functioning 10 years later. And again, both of these papers are now published, and I'm happy to share them with you. But basically what we found is that those in the high functioning profiles 3 and 4, which is the blue and purple bars here, that these individuals continued up to 10 years later to have greater purpose in life, less depression, lower anger, and better self-reported health than those in profiles 1 and 2. And again, these sample sizes are pretty small, but it gives us a clue that some of these profiles, that this recovery might have been maintained for a longer term. Some new data that we're really interested in is throughout all of this, we became really interested in profile 2, and how these individuals were, one of my grad students, Anna Wilson, said, doing the hard work of recovery. They mostly reduced their drinking. A third of them were abstinent, but we're still not doing well. And so we thought about, well, what about community level factors that might explain these differences? And so these data are now under review. But what we found is that the high and low functioning profiles generally could be somewhat differentiated by community level factors, and particularly community level economic factors. So here is community level income, and this is based on site. So we don't have a ton of sites, which is why these data look very, very messy. But basically what we see here is that profile 1 in particular has very low income, as well as profile 2 versus profile 3. So this is kind of the average income at each of the sites. So community level income, not individual income, but community level income. So the average wages in the site where these people were recruited from. And these were significant differences between the low functioning profiles and profile 3. And then we also had a measure of income inequality, where higher income inequality would be worse. And what we found again is that particularly those in profile 1 were in communities, individuals in this profile were in communities with the highest income inequality. And so, this kind of really speaks to the need to be looking at these social determinants of health and systemic racism and other problems in these communities that are actually, preventing people from achieving a higher functioning recovery outcome. So I think, some of the take-home messages of these studies is that in these 2 independent samples, even those who had heavy drinking, there was considerable functional improvement that was maintained. Now, we don't have biomarkers of physical function in these data sets. We don't have measures from family and friends who might be impacted by alcohol use. We have limited sample sizes, and the generalizability of these initial samples are also, a question because they're clinical trial samples. But I also think it for me, leads to a lot of questions and kind of ways to think about recovery. And I'm happy to kind of have a discussion with all of you about your additional thoughts. But, if we think back that most individuals with AUD are not severe, that recovery of functioning, well-being, and quality of life might be a better target than thinking just about abstinence or not, because we see that even those who achieve some abstinence are not necessarily achieving functioning well-being and good quality of life, at least in these data. And that these community level economic factors may also be important, not surprisingly. But I think coming back to this public health perspective, that the abstinence focus of many treatment programs could actually be a barrier to treatment seeking. And when we look at contemporary samples, most people coming to treatment with alcohol use disorder actually don't want to abstain. They want to reduce their drinking. So from that perspective, I think, can we engage more people in treatment if we look at drinking reduction? And again, I'm going to come back to this kind of public health impact. So if we think about, and this is a lot of like back of the postcard math, right? But so it's all just making stuff up, but based in data. So if we assume that 12% of US adults with a current alcohol use disorder have a current alcohol use disorder, that's about 30 million people in the US with a current alcohol use disorder based on current estimates. And if we think about the fact that only 20% of those with alcohol use disorder seek treatment, and most of our treatment programs continue to be abstinence-based, that's about 6 million people are seeking treatment with an alcohol use disorder. And then if we focus on abstinence as success, and only about 36% of individuals achieve abstinence in treatment, then our success is treating about 2.2 million people are going to achieve this definition of success, which again is about 7% of people with an alcohol use disorder. If we look at the same set of people, so 12% of people with an alcohol use disorder, 30 million people, And then we say, well, what if we expanded our treatment to be focused on drinking reductions? And if we can assume that 50% of people, the 80% with a current alcohol use disorder would seek a drinking reduction treatment, well, now we're talking about 12 million people who might seek treatment. And of those, if we assume that 77% of them are going to achieve success with drinking reductions, now we have 9.2 million people who have achieved success with drinking reduction, or about 30% of all of those with alcohol use disorder. So basically, it's kind of saying that, you know, if we stick with an abstinence model, about 2.2 million people are going to achieve success with that model. If we move to a drinking reduction model, potentially 9.2 million people would achieve success with that drinking reduction model. So we're reaching more people, we're potentially helping more people and reducing their drinking. So, you know, I think a bigger issue, though, that I want to end with, and these community level factors have me thinking about this, but also a lot of the other work I do, that, you know, for too long, I think in our field, we've really been focused on the individual and the individual's alcohol use, and really not examining and targeting the causes and conditions that bring people to heavy alcohol use in the first place and that maintain heavy alcohol use. So if we think about more of a socio-ecological model of both examining, so studying alcohol use disorder, but also targeting alcohol use disorder. And a recent paper just came out on looking at policy interventions, particularly geared towards opioid use. And what they found is that a lot of these policy interventions might have had unintended consequences. And they conclude that it's really important that we start looking at the fundamental causes of overdose deaths. And that includes lack of economic opportunity and persistent physical and medical pain, rather than just the access to opioids, right? Like, and so if we think about this with alcohol, access to alcohol is everywhere. Alcohol is legal in the US. And so, yeah, our treatments are continuing to just target the alcohol and not looking at the causes and conditions. So I'm actually going to pause here to do a bit of an activity, which is hard via Zoom. But so I want to just take a moment for everyone to just do a little mindfulness practice, if you would. And you don't have to do it because I don't know that you're doing it or not. It's in your head. But if you could just kind of take a moment and come into the body and really think about something you engage in that you don't love about yourself, something that you kind of automatically do. And, you know, maybe it's checking your phone, maybe it's checking the news, maybe it's watching TV, maybe it's drinking, maybe it's using drugs, whatever, something that you do kind of automatically that you don't really love that you do, but you continue to do it, even though you don't really love it. Maybe it's the additional dessert, maybe it's the binge watching a show, but something that you do and maybe habitually do that you're not really loving. So if you can just kind of do a little visualization of that activity. And I'd like to ask you, what are you really seeking when you do that? You know, when you reach for, if it is, you know, checking your phone, when you reach for your phone, what are you really seeking? Or if you have that dessert, what are you really wanting? If you are binge watching a show, what are you really seeking? Like, what do you really want? And you don't have to share this. I could ask you to put it in chat, but I won't. But if you could just really think about that, what are you really seeking? And we actually do this practice in our mindfulness-based interventions. And what we find, and I imagine for many of you might have had similar experiences, we find that people are also often, you know, when we work with people in recovery, people with substance use disorders, what they're seeking is relief from pain, social connection, to feel joy, to have fun, to be numb, to get away, to get relief from boredom, to not feel so bad, or to feel good, or to experience some joy. And when we look at these things, we see really kind of humble and wholesome human needs. And I imagine for many of you, when you were thinking about what you're actually seeking, it was humble and wholesome and kind of those fundamental things that we need and want as humans. And so how can we help people tap into these things, regardless of what they're putting in their body, alcohol or drug wise, but tap into these things that they're really seeking? What if that were the focus? What if we focused on the community and what they need from their community to feel social connection, to feel joy, to have fun? You know, there's some really interesting, I've been diving into this community literature, and there's really interesting literature about like alcohol outlets and green spaces, and like the level of substance use disorders and alcohol use disorders based on alcohol outlet versus green spaces. And just thinking about that, right? And just thinking about this feeling joy and having fun and social connection. If the only way to connect with people in your neighborhood is bars, you might choose to go to bars. Whereas if you have green spaces and parks and bike trails and other places where you can experience joy and social connection, you might be more willing to do those things, right? And so really thinking about not just this individual and what they put in their body, but the context in which they live and how we can help these contexts, how we can help provide what the person is actually seeking. So I also think from a public health perspective that focusing on drinking reductions broadly would depathologize and destigmatize alcohol use disorder, because it really helps us shift from a pathology-based model to more of a strengths-based community social ecological model. And I really think that this requiring abstinence is perpetuating this kind of us versus them stigma of alcohol use disorder. You know, if you have an alcohol use disorder, you have to be abstinent and can never drink again. If you don't have an alcohol use disorder, you can drink as much as you want. It's celebrated, right? And so I really think if we shifted to a reduction-based model for everyone, you know, focused on health and wellness of drinking reductions, that it would help reduce the stigma of alcohol use disorder. And I also think, as a sidebar, and we talk about this at length in this paper, which I'm happy to share, that these notions, like in the Betty Ford definition and the SAMHSA definition about citizenship and service, are also potentially misguided and could further exacerbate stigma. Because if we think about, you know, individuals who are struggling already with their alcohol use disorder and maybe are not in contexts that they are able to engage in citizenship and service, and you know, but they can kind of get help for their alcohol use disorder, reduce their drinking, and be in a better place for themselves and for their wellness, that maybe that's citizenship and service enough, that there doesn't have to be this extra layer. This Carrie Lancaster in Australia puts it as like, all of a sudden you have to be not only recovered from your alcohol use disorder, but also the superhuman who like gives back to the community. And it's like maybe that's taking it it's just that one step too far, and we should be more focused around well-being and purpose in life, whatever that purpose might be, even if it's not service and citizenship as kind of traditionally described. So, you know, I think you know, that we need to be thinking about drinking reduction and to develop and disseminate culturally tailored, culturally informed interventions that target drinking reduction. I think that a focus on non-abstinence could reduce stigma, improve access to care, increase treatment seeking. And that also, our latest work is really kind of identifying that there's potential racial inequities and that social determinants of health, systemic racism, all of these things are barriers to wellness as well. And so we can't just be myopically focused on individual drinking. We have to think about these community level factors. And here's just some examples of that, of expanding access and services and focusing on community to meet people where they're at. So Ayanna Jordan at Yale is doing really great work on not thinking outside of the traditional alcohol treatment box and substance use disorder treatment box of moving into kind of doing this work in Black churches to try to reach Black individuals with alcohol use and other substance use disorders. Work by Susan Collins and Seema Cliff-Asefi and others at University of Washington, focused on harm reduction treatment for individuals who experience homelessness and alcohol use disorder who were not treatment seeking, but would be willing to take extended release naltrexone, and found really good improvements in drinking reductions and quality of life. And then some work I've been involved with Kamala Venner has been looking at, can we culturally tailor evidence-based treatments with an American Indian Southwest tribe? And so really focusing on working with the tribe to identify what they define as kind of successful outcomes for individuals in their community. So I think these are just a few examples of how we might be could move in this direction. So I have a lot of people to thank. Mostly, this work I do it with and for trainees who I get to work with, and they inspire me to do this work, and of course, current funding.